what I'm going to talk to you about is kind of getting lean, ways to make your department a little more efficient, maybe operationally as well as cost-wise. And the costs can be departmental costs, but they can also be just overall healthcare costs. Because I will assure you, even though you think it's kind of a lofty conversation of, oh, let's not worry about healthcare costs, it doesn't impact us. Well, it does, and eventually, in the very near future, everything you order as a department and as a physician is going to be assigned to your provider number. It's going to be. And you're going to be accountable and responsible for that utilization. And also, everything you order gridlocks your department. You ever notice that? Did you ever notice that if you're deciding, boy, should I get the urinalysis or should I just treat the person empirically for their UTI? The minute you put one order, one lab test on the chart, you have added 30 minutes minimum to that patient's visit, don't you think? Absolutely, because you're not going to stand by the printer and wait for that result to come back. So the minute you do that, not only have you spent hard dollars, you've also spent operational dollars, which are very, very hard to get back. So let's hit a couple items, and I'm a little bigger than Sherry, so Rick will not be able to stop me. I'm going to keep going until I'm done. So you can try, buddy, but I'm going to keep going. But I think I've got like 30 slides and 30 minutes, so hopefully we can hit all these for you. What we're looking for with improved resource utilization and efficiency are better outcomes. We want our patients to be happier. We want to be doing a better job quicker with less resources. Wouldn't that be great if we can do that? Has anyone ever worked with a provider, a doc, or anyone else who thinks they give better care by checking more boxes? I have done a great job today. I have run through 5 pens and checked every box on the chart. I work with some of those people. The interesting fallacy about that whole thing is that the people who check more boxes actually don't give better care. They want the boxes to give them the answers, the tests to give them the answers. They spend more money, it takes more time, and their outcomes are no better. They're actually worse lots of times. Less time, less resources, better outcomes. We want improved revenue, and reduced costs is going to give us lean operations, lean financially and lean operationally. I mean, I know you guys you've heard the whole Six Sigma thing, and you've heard the lean Six Sigma thing, where it's let's not tolerate any error. And then once we've done that with Six Sigma, we've just created a monster that is so hard to deal with, it takes 52 hours to get one person through the department. The lean end of it is to say, okay, now how do we do that and remove some steps that aren't necessary? Some non-value added steps. We've got to get rid of those steps. Anything that's in the way of the patient getting their care, in the way of the patient and the nurse, the patient and the doc, needs to get out of the way. Anything you're not using, you just need to get rid of. And I know my kids, I think until maybe 25, you don't use your head, so we could probably just leave it at home. But get rid of the wasted things that we don't need. Operationally, this is interesting, right out of the Annals of Emergency Medicine. I was unaware of this, and you may be unaware of it also. Direct cost distribution in the ED, 85% is human resources, 7% supplies, 4% are purchase services. So where are our operational inefficiencies financially? Are we buying too many crutches? You ever been in that discussion? That's it. We're going to write prescriptions only. We cannot provide crutches for people. You guys have had those conversations, haven't you? Just one person, please help me here. Okay, thank you. More than one. We don't all have to help. I just needed one. But yeah, we have those conversations. If you know this data, supplies are 7% of the cost. We've got to manage human resources. And I heard Sherry mention some things as well. You know, are there ways to make things more efficient? Do we need to do a highlighter for every order? Do we have to hire somebody who's a highlighter expert? Got the pink and I got the yellow, which we're using today. That's probably a wasted step. Maybe it is, maybe it isn't, but we've got to look at these things critically. Staffing models are critical. Has anyone talked to you about staffing models yet? Okay, that's one. Thank you. Okay, it's coming. I'm just going to touch on it here. So what do you want to do? Do you want to staff for surge? Or do you want to be able to flex up? What I mean is we oftentimes staff our emergency departments for the worst case scenario. And then we have lots of break time and donut time and downtime when we aren't really, really busy, right? We need to get to the point where we're allowed to say, listen, don't come in today. Or don't come in for a couple more hours. We don't need to spend that money. Oh, I'm sorry, I promised you those hours, so we'll just go ahead and spend the money anyway. We have to change our culture and change our thinking. We have to be ready to flex up to meet the demand. Question? When we do this, and then we
flex down.
Oh, when you flex down, absolutely.
The morning's not busy, and then the shit hits the fan at 11 o'clock.
So we've already degraded to that point, have we? So the shit hits the fan. We're already swearing. It's been like 5 minutes. You're swearing at me already. So, no, I mean, the shit does hit the fan, and I'll be honest with you, it's a very good point. Can you flex down to the point where you can damage your operations? Absolutely. Know what you're doing, and know what your census looks like, and know when you ramp up during the day, and make sure that you have somebody on call. At a lot of our sites, and when I was my last medical directorship quite a while ago, I used to have somebody on call, $50 or $100 a day, I don't remember what it was, and you had to be available within 30 minutes to be in the department. Do whatever you want on that day, but you have to be here. When I call you, you need to be here. But I'll be honest with you, most of the times we were asked to bring the doc in, it was by administration or someone else, and the solution to every crisis in the ED was, we need more physician coverage, get another doc. And oftentimes that really wasn't the fix. But nursing-wise too, I think this discussion really speaks to both ends of it. You're right, we don't want to flex down to the point we can hurt ourselves, but we have to be mindful that at a moment's notice we need to be able to flex up. So if you think you can draft 2 FTEs, maybe just 1. Just make it reasonable, but we've got to make it cost efficient is what I'm talking about. Okay, RNs, LPNs versus techs. You know, are we having a hard time finding nurses? How many nurses are in this room? So we're not having any difficulty finding nurses within this room. So that's fine. But as far as hiring more nurses, what you do is extremely valuable. And what we do as a system is devalue you. Okay? How many hours a day do you spend dumping out the commode? Enough that it doesn't make any sense. One good thing about that is I'm glad you're doing it and I'm not doing it, but there are times that I do it. And did I just say do? I think I did. I think I did. That wasn't even planned. But seriously, we need to make sure that our nursing resources are used well. And how can we provide the right resources to the right task? If nurses are splinting, do they need to? Can we have paramedics or other type of techs doing all kinds of procedures and all kinds of activities that the nurses can be freed up for to do other things, and the docs can be freed up to do the right things as well. And if we do that, we can be more efficient, and I'll show you how. Mid-level providers. Anybody have mid-levels in their department? And anybody not have mid-levels? They're coming. Depending on your volume, I mean, if you have, probably more than a 30,000 volume ED, at some point we know, looking at the workforce studies that have come out recently as well, we're not going to staff these departments with emergency physicians, particularly rural emergency departments. It's just not going to happen. And I think we had this pipe dream in the past that let's turn out more residents. And what we're doing is we're turning out more residents that want to work in LA County, more residents that want to work in Chicago, more residents that want to work in Dallas. But I don't see more residents going to Wyoming. Do you see that happening? I don't. And so there's still, unless you can incentivize those docs to go to places that they originally wouldn't want to go to for whatever reason, we're going to be left with the same problem. So we're going to have to use mid-levels. Okay. But they need appropriate supervision. Critical leverage points of efficiency, what can they help us with? Managing wounds is probably the biggest one. Well, if I can be freed up and not have to spend the time with a wound, I like managing wounds, but it takes some time. Selective use saves money, it really does. We use them to help us as physician assistants or nurse practitioners. It really helps if we use them the right way. But overuse ultimately costs us money. How can it cost us money if we don't use them the right way? What's the one big way? Anybody? Is there a nurse in the room? That was an easier question. Okay, nurses, yes, they're there. But if we use mid-levels in the wrong sense and we extend them beyond their scope of practice, what can happen? Bad outcomes. People get hurt, and I'm telling you, there's a significant risk for malpractice claims and lawsuits. All right, here's a good example of that exact concept. This is one of the cases from one of our sites. 34-year-old male patient with a fibular fracture. Returns to the ED with increased pain. Repeat radiographs are unremarkable. Additional analgesics and discharge. Seen by, I can tell you, we have a couple different parts of our group. One part of our group, all patients who are seen by a mid-level must be seen by a doc. They have to be. And that part of the group feels that every patient gets the benefit of the doc seeing them, okay? Another part of our group is a little more flexible on that. And they say, no, in some cases we can let the mid-level just see the patient on their own without our involvement. And that's what you have to decide. What's reasonable, what's realistic, and also what's safe. So this patient was seen by the mid-level, looked at the case, said, oh, you know what, you need some more pain medicines, we'll take care of that. And what happened on visit number 3? Severe pain, loss of pulsus fasciotomy. What did this person have? Compartment syndrome. The eye does not see what the mind does not know. The mid-level's like, compartment what? I mean, they didn't really think about that. Would a doc have missed it? Maybe. But we know they would have had a better shot at making that diagnosis had the doc been involved. Here's what's on the record from the doc. agree with above, and that was signed after the patient went home. Is that happening in your departments? It's happening all over the country. Here's a stack of charts. You trust your mid-level. Why? Because it's convenient to trust them and you believe that in the low acuity cases, everything's going to be fine. And do you always know your low acuity cases are low acuity? That's what I'm hearing, that, oh, mid-levels can function in a fast track. That'll be fine. Okay, so every sore throat is just viral pharyngitis and none of them are epiglottitis? Every person with a fracture just needs more pain medicines. They don't have compartment syndrome? This is the issue with assuming all low acuity visits are appropriately sent to the fast track, and they aren't. Sometimes we don't know they're low acuity or they're higher acuity. All right, staffing, saving money a bit. Let's be efficient and save some dollars. And I would say too, if you're not focusing on your left without being treated, your dollars are flying away. They really are. And does anyone here have a left without being seen or left without being treated rate of less than 1%? Okay, a few hands. Well, we're done then. We'll go to the next slide. But if you do have any left without being treated, this is revenue walking right out of your department. This is risk walking right into your department. This is a potential EMTALA violation walking into your department as they walk out. They didn't get their medical screening examination oftentimes, so this is a concern. Take a look at it this way. Instead of being kind of an employee mentality versus an owner mentality, if we say, listen, if a patient walks out, you can either say, great, it's one less patient for me to see, or if we see 2 additional patients per shift, look at a small department, 5 docs, 2 additional patients per shift, just 2, okay? If say, and this is very, very conservative, but let's say $100 collection per visit on the average. That would be an extra $219,000 collections annually, and that would equate to about $40,000 or $25 an hour per hour raise for those 5 docs. Do you think those docs would appreciate that raise, particularly when we're at risk of our compensation going down? Could that money, if it's an employee situation with a hospital, could that money be sent towards something else to make the department better? Yes. Could we use that money to incentivize our team to do the right things and improve our behaviors to make the care better in our departments? Yes. And that's because we have to change our mentality. Patients walking out isn't a load off of our shoulders. It's a failure of the system, and it's an individual failure when we're working. Just 2 per shift, if we can see them, makes a big difference. All right, provider and triage. Anyone have a provider and triage besides nurse? Either mid-level or physician and triage? Okay. We're implementing this and have been the last couple of years at every site we have. This was the first site that it was piloted at, and I'll just share a little bit of data with you. Triage doc versus traditional. Length of stay, 41.4 minute decreased. Overall length of stay, substantial. Left without being treated, 44% reduction. Do you think they made extra money that year? Were they happy to work those shifts? Yes. The docs are happier, everything's running more efficiently, everybody's happier, and the whole thing works better. The found money there was $125,000. What are you going to do with it? Whatever you want. The key is it wasn't there before. You got more efficient. We found that in the average department, 30% of those people don't even have to be sent to a fast track. They're discharged right from triage. The triage area is largely your fast track sometimes. It works great. All right, let's incentivize performance. Pay for improvements that generate revenue. How can we generate revenue? Well, let's see a few more patients if we can. If you have any left without being treated, you've got a pool of patients you can see. And how about improving productivity? Beyond seeing more patients, you can document better and smarter. You know, you've already provided the care, and at least on the physician end of things, we tend to devalue what we do. And we don't document everything that we've done because we don't think that it's all that concerning to us. Good example is critical care. Take a look at critical care documentation across all medical specialties. It's not documented well enough. It's under-documented, and because it's certain things like chest pain, for instance, that we treat with nitrates and aspirin and oxygen and a couple of EKGs, and by the time we work them up, decide to admit them or whatever we're going to do with them, and it wasn't acute coronary syndrome as far as we can say, we retrospectively deny ourselves and say, oh, well, it wasn't that concerning, so I guess it wasn't critical care. Well, if you look at the definition for critical care from a CPT standpoint, if you were concerned that they might have had an imminent or probable life-threatening deterioration, and acute coronary syndrome certainly falls into that category, you just provided critical care services and you did not document it. And that's money walking out your door. Take a look. You know, the difference between a level 2, which we are not documenting very much, but it's under 1 RVU. You go up to the first level of critical care, you're 5.5. As of 2009, how much is the government paying us per RVU? $36. How much did you add by documenting critical care as opposed to having poor documentation? quite a bit. And you're not stealing from anybody. This is money you earned that you left on the table and you decided, you know, my sphincter tone wasn't enough, so this couldn't be critical care. There's nothing in the CPT definition about sphincter tone or whether you needed to change your underwear. Just because you're good at doing these things doesn't mean it doesn't meet the definition. Yeah?
I don't get nervous when I document critical care and I send somebody home. Have you ever done that?
I've done that. I do that all the time. Now, he said he gets nervous sometimes. Do you get nervous a lot? I mean, we have to have a deeper conversation. Okay. Someone hug him. He looks like he needs a hug. But he's nervous when he's documenting critical care and sending somebody home. Now, there's no prohibition to documenting critical care when you're a DNR patient, when you're sending them home, those type of things. But your documentation better really be very good to show what you were treating so that it's clear that the patient was meeting the definition, but they were also well enough to go home. So don't be scared, but just document it well. What you need to do in a nutshell is make sure they meet the definition, and then tell them in the record, this is what I was worried about. It was a kidney stone, ultimately, but I was worried about AAA. I got a CT to look for that. Even went over to radiology and looked at the CT before they came back. It ended up being a kidney stone, but I provided critical care services. And so, the question here? Mine personally? Mine personally is about in the 12% range. Yeah. If you're at a place that has, it's an RVU-rich environment, a lot of sick patients, a lot of patients to see, it's not necessarily hard to do if you follow the definition. I'll be honest with you, I monitor that for our group, so I think mine is higher than some, but certainly well within a reasonable range. And we do is we monitor as well. Anyone who is over 2 standard deviations above the average at their site, we audit those charts. So we kind of keep an eye on that too, because we do have incentive-based compensation, and that's a good thing, but also sometimes this is an easy place then to say, well, it's easier to document better than it is to see 2 more patients, so maybe I can just document better. And you should, but you should never ever document something you haven't done or something that isn't supported by the CPT nomenclature. All right, well, let's move on with a few more things. Diagnostics. What kind of tests do we do that take up our time and spend the patient's money? And ultimately, it could be our money. Do you guys like ordering amylases? How many times, this is one of my pet peeves, for abdominal pain workups, it's oftentimes a checkbox to order both amylase and lipase, amylase and lipase. Has anyone ordered or seen in your department an amylase ordered in the last year? Okay, now I know you're asleep. Okay, 1 person. Okay, 2, thank you, Sherry. Okay, the last month, the last week, probably since you've been in this room today, absolutely. They're ordering it all the time, makes me crazy. Here's the interesting thing. If you look at the data on amylase and lipase for pancreatitis, lipase is more specific and more sensitive. Amylase adds nothing, adds absolutely nothing to the diagnostic predictive value of anything, including pancreatitis. So here's the price. You call your lab, it's right around this area. This is what it is at my lab. So lipase, $59, amylase is $53. The average ordering pattern, let's say that you have 3 abdominal pain workups and you order 3 per shift. 15 shifts per month for a 20-year career, and how much are you spending on a test that gives you nothing in return? $500,000. Were you saying you order them all the time? Right. It's a charge and not the cost, but nonetheless, the insurer pays it frequently, depending on who the third-party payer is. You're right. There's a distinct difference between charge and cost. But they're sending those charges out, and who knows exactly what they're getting back. But it's interesting to know, and it's easier to track sometimes what we're charging than exactly what the cost is, than what the cost is. What we're charging and what we're getting back are 2 different things, depending on even relationships with third-party payers. Here's our charge, but we're going to give you 105% of Medicare, whatever it is. But I think this is important, and even if the numbers can be tweaked differently, I want you to think of the concept, because I think the concept is true either way. All right, BNP. Maybe this one's a little dicier, okay? You ordering a lot of BNPs in those CHF patients in your department? You order them. We're going to have to talk later. You have time later? Well, you're the one that said, bad data is better than no data, so go ahead and order it. That's what you're getting, bad data. Seriously, in a nutshell, with the BNP, you look at all the data that's out there, and most of it by far was really pharmaceutical sponsored or corporate sponsored for these studies. But if you look at it, what were we looking for? We were looking for something in those gray zone cases where we couldn't tell whether it was a pulmonary or a cardiac etiology for dyspnea. We needed help. And this test just doesn't get it done when you look at that subset of patients. It doesn't. Now what happens is you'll see somebody with congestive heart failure, somebody orders a BNP, and the BNP is 5,000. And then the person says, see, the BNP works. as they wipe the frothy sputum off of their lab coat. I mean, did you examine them? Did you look at the chest x-ray? You had the answer. Why do you need a $43 test to confirm what you already knew? You didn't need it. And those who you know don't have it, they have a fever, you know, they're a COPD patient, they don't really seem like they're CHF at all, their BNP is 20. Well, it worked there too, but we didn't need help there. The test really doesn't work the way we wanted it to, but it does cost money and it takes time. I'm seeing people order it as a cardiac marker, and it's not really effective that way either. So take a look at it. 3 order per shift, 15 shifts, 20-year career. Sherry, you're spending almost $500,000 at the end of your career. You like to order it though, don't you? Behind the back, 5 per shift, you're spending this much. Okay? So scary. If it's not helping us, it's slowing down the lab. And because they're doing this, you're not getting the troponin as fast as you want it. Okay, stool for occult blood. This is my favorite. You know, once every 6 months at the 2 hospitals I work at, someone will say, oh, don't forget to get 2 stool cards. I'm like, why? You hungry? I mean, why am I getting 2? Oh, we have to send one to the lab. Not on my watch, you aren't. Why do we send one to the lab? So the hospital can bill for it, right? That is the only reason. Why? Because I can't figure out, first of all, if there was poop on the slide. I figured that. I was in the right place. And I'm not colorblind. So we've got this figured out. So why send it to the lab? It doesn't make any sense. If you do send it to the lab so they get their share, it's $15 for one of these occult blood tests. Wouldn't it be great if we got paid that much for it? We don't. If you do 5 per shift, I don't know if you're really into rectals, but maybe you are, 5 per shift, 15 shifts per month, 20 years, how much money are we spending on just sending one to the lab so they get their piece? Is that wasted money? No matter how much we're getting back on it, is it a waste of money? It definitely is a waste of money. There's no value-added service there at all. Do you want your lab tech focusing on that or something else? Okay, now I've got, this is a little, kind of an analogy I want you to work with me on here. You guys will pick up where I'm going. I looked at this and said, wow, I've been flushing this stuff for years. If you take a look, what other substance is with $866 per ounce or 28 grams as of the close of the market at the end of 2008? Anyone? Anyone have it yet? No, you don't have it yet. Okay, let's keep moving on here. So if our sample on the end of our glove is 1/57th of an ounce, and I've measured it, I think it is. It must be. Then one sample times $15, that's gonna get us to the $866. So every stool sample is $866. I know what I'm doing. I'm quitting medicine and I'm going to start selling crap. I mean, this is going to make it a lot easier. This is the price of gold. The price of gold. What are we charging people for? Some stool from them? That doesn't make any sense at all. Urinalysis. This one makes me crazy too. $64, okay, for a regular urinalysis. I'm not kidding. 4 order per shift. It might be more than that. 15 shifts per month. You guys can recite this with me. 20 years. What are we spending? A lot of money. And a lot of these are the 20-year-old with urinary frequency, dysuria, urgency. What would they get if they went to the family doctor's office? A prescription, a lovely prescription, and go home. Again, you write the order for the urinalysis, and they're there for 30 to 60 minutes longer. When you could just hand them a prescription, maybe a dose of pyridium for their comfort, and show them where the door is. They go right back out. They're gone in 10 minutes. I love those visits. But let's not add unnecessary inefficiency to it. Rapid streps. We know the data says, hey, if you meet the criteria and you have no viral upper respiratory symptoms, you got pus in your tonsils, you got fever, you got a headache, sore throat, what do you have? You probably have strep. So we really shouldn't be doing very many of these. And when we do them, $69 to swab the throat, okay? Now, how many of you, your lab, when you have a negative, you do an automatic culture just to make sure? Oh, absolutely. Yeah, most of us do that. That culture they're adding on is $103. That's not like a bargain coupon deal. Well, $69, and if yours is negative, you get a culture. It doesn't work that way. They add it on. So 15 shifts, 20 years. If we have one of these per shift, and one that's positive that we order, and it's positive, we already know they have strep, that's a lot of money wasted for something we were going to treat anyway. Let's say that we have one that's negative, we add the culture. There you go. Let's say we do 2 a shift, one that's positive, one that's negative. That's how much money we're spending on this test. And it takes time, doesn't it? It does take time. And how many docs, where are the docs? Are you swabbing it where you're in the room, or you're saying, you know, nurse to pick up the swab, or is it you're kind of the same doc that says nurse to digitally disimpact? I was already in there, but I had to get out. I got more important things to do. You are so much better at this than I am. I'm not qualified for this. So be careful with that. And my favorite, urethral swabs. How many of you are swabbing male urethras when they have dysuria? Go ahead. Oh yeah, I can tell. I can tell. You had a bad experience, didn't you, at some point in your life? I'll tell you what. Lots of times I think this is punitive. Why are we doing this? What do men have, young men have, when they say, here, I have knee pain? It's not knee pain. It's weenie pain. It's bad, and it burns, and I've got this discharge. What do they need? They need to be treated. GC chlamydia, need to be treated, throw some Flagyl on board, and they are set. And that's all they need is to be treated. Now, some people will say, well, wait a minute. Don't we have to report these infectious diseases? That's oftentimes the argument I hear. We've got to report these, and that's why we must swab them. We're doing a public service so they'll remember never to have sex again. And also so we can report this. Remember, too, there is legislation out there that you have to report these identified sexually transmitted diseases. But there's no legislation that says you have to swab them in order of culture, because who's paying for this? The patient's paying for this, and if they can't, we are. They can't mandate that the patient will pay for a service for surveillance. They can't. So you don't have to swab these people. And again, if you do it, $212 for the gem probe. Okay? 1 per shift, 15 shifts per month, 20 years. And you think we're stopping these people from going out on a Friday night? It's not happening. They're going to forget very quickly. The medicine worked, and all right, they're back in action. And if this is what your department looks like, you're going to try and deter people with this giant Q-tip. All right, remember, be safe out there. This is hilarious. Nurses at whatever, I think it was Wilcox, demanded safe staffing. Well, if you have a Q-tip like this, trust me, all 20-year-old males will never come to your department. Your census will drop. All right, top 5 overutilized radiographs. Head CT for syncope. Are these routinely ordered? It take a lot of time, and it's a lot of money. It's about a $500 to $1,000 decision on this thing. And let's talk about it. Do strokes actually cause syncope? What are we looking for? And to have a stroke, an ischemic event that causes syncope, you have to have one of two things. Either a bihemispheric event, or you've got to have an event in the reticular activating formation of the brainstem. How many people have no neural symptoms before their syncope and have a normal neuroexam after the syncopal episode and have one of those two things going on? 0. None of them do. So don't order the CT. It's a wasted step. If the person who's admitting them wants to order it, they can get access to all the tests we can. They can order it upstairs. Rib details. Patients want to know if they have a broken rib. Is that why we order it? So tell them, wow, that hurts. You have a broken rib. They want an answer. Don't need to get the test. Back x-rays. Wow, I lifted a box. I moved a refrigerator. I have back pain. Sometimes it's just easier to say, I can order a lot of tests and occupy your time and make you happy, or I'm going to have to spend time with you and explain why you don't need them. Let me think. I think I'll just order the test. I think lots of people do that. But back x-rays are rarely needed, and we order a lot of them. A lot of radiation exposure, a lot of time. Acute abdominal series, what I don't like about it is people order the acute abdominal series and then they order what next? CT, it's like a prerequisite, I can't order the CT unless I get the entry-level test first. I've got to get the... Doesn't make any sense. Nothing is lost on the CAT scan. You see obstructions better, you see everything better. If you know you got to get the CT, just get it up front. Saves time. Knee films. This is an amazing statistic, I think. We get knee films all the time for people who don't have any risk for breaking their knee. They twist their knee, or they're in a sport, or whatever it is, and they obviously have ligamentous injury or a cartilaginous injury, and we order an x-ray to look for what? For a fracture that's not going to be there. You can tell them they need an MRI, but they don't need one today. If they get better in a week or two, they don't need any tests. But if you order, it's kind of interesting, you look at the data from the entire nation, and if you order 1 unnecessary knee x-ray a day, and I think we're ordering more than that, the hospital gets reimbursed by Medicare $45. The physician, $18 for reading it, okay? So if we take a look at this, all emergency departments across the country ordered 1 less knee film a day. That's how much we save. And that's actually what Medicare is paying, reimbursing for this. Can you think of any time you worked in the last couple of weeks where you knew the person didn't have a broken knee and they got the x-ray anyway? You know they did when you think about it. It happens all the time. Don't order those. Okay, treatments. We'll run through this quickly. Think about what they get in the ED, and oftentimes self-administered medications are not reimbursed for your hospital at all. It's just goodwill given to the patient. 50 received antibiotics in the ER. We took a look at this for UTIs, and take a look at the things that we're given. A dose of Levaquin PO for 21 bucks. Wow, that's a lot to spend. Write the prescription. If they need it, fine, and maybe choose something that's reasonable. Antiemetic use. This is a little data, but just to show you what we went through before ondansetron came off of patent. And we had a lot of patients that were getting this as first line at $48 a shot, IV, and ODT, $46 before it came off patent, when we had other very reasonable choices that were much less expensive. much less expensive. So you can take a look at your Diebold or your Pyxis, whatever it is, and run the medication list and see what your patterns are and what you can fix to make better. This is recent data with Dancitron at Triage. Anyone doing this? Even if someone thinks they're going to be nauseated, you need to drop an ODT in their tongue, under their tongue and send them into the ED. Particularly with kids, great data on this. Great data to say if they're nauseated, you can decrease the likelihood of IV fluids being necessary, and you can orally rehydrate them, and their length of stay is significantly less if you start this early. Hep block versus TKO. How many times do we start IV fluids to keep the vein open? Does the vein close? I've never heard that before. I've never understood the KVO to the TKO. Well, you got to keep the vein open. When does it close? It doesn't close. You know that extra tubing and that extra secondary set on the IV fluids, anywhere between like $85 and $150 extra. And the patient will get charged for that. Look at the American Journal of Emergency Medicine, 1987. Said if you just go to the hep block, even back then it was a 60% reduction in cost. They were talking about it then. Don't hang fluids if you don't need fluids. Waste of time, waste of money. All right, so let's take a look at the average day in the ED regarding diagnostics and see if we can make an impact, all right? If we have roughly 25,000 active ACEP members, roughly, okay, running around out there, taking care of patients, each works one shift per week. It's not a bad life, right? One shift per week, they're not working a lot. And let's say each orders $538 of wasted tests, 2 rapid streps, 1 knee x-ray, 2 UAs, and 2 amylases. Are we in agreement for the most part that a lot of times those are going to be wasted tests? Okay, thank you. At least one person is, so good. I'll pay you later. I will do it. I've got some drinks for you back there. They just rolled them in. Okay, good. All right, so what's going to happen in the course of a week? Over $13 million for all those docs working one shift a week, okay? We take a look at 52, the whole year, almost $700 million in waste that we can get rid of. Plus, again, there's all that operational inefficiency that we have for tests that just aren't making things better at all. Okay, now as far as productivity, the average day in the ED. See one more patient per shift, and we said let's increase, let's say we get collections 100 per patient, that's $100 per day that we wouldn't see on the physician side. On the facility side, it's going to be even more. And can we increase collections by $10 per chart based on what I was just touching on critical care? I can guarantee you, if you document better, clearly, $10 per chart, unless you are doing great with coding and billing, is not a stretch goal. That is very reasonable. Take a look at a 40K volume ED, $1,095 per day is what we're going to do better with regarding $10 per chart, and that's $400,000 annually. Can anyone think of a way to spend $400,000? I think you can. No, you're not buying swabs. I saw the look in your eye. No, we're not doing it. All right. What about staffing? Reduce 2 hours of physician coverage. Not because we don't want to provide the coverage, but because we get so lean, so efficient, we just don't need the coverage. And maybe add 1 hour of mid-level provider coverage back. You know, the net would be approximately $250 a day. Let's say with benefits and everything, you're paying a doc, I don't know, it's just a ballpark number, $150 an hour with everything. And maybe paying the mid-level $50 to $60, take $300 off, add the $50 back, you get $250 a day savings. Annually, just by making this change, $91,000 back to your department. Can you spend that money? I'm sure you can, to make things better for you, safer for the patients. All right, the average day big picture. Increase the revenue, 100 plus for those patients. $1,095, we talked about that in the 40K volume ED. Decrease the cost. We're going to decrease it by $250 by making the staffing change, excluding inefficient ordering. If we put a provider in there that orders more tests, it doesn't help us. The total is $1,445 more net revenue. 4,000 EDs roughly in the country. That's over $5 million a day based on CDC information for volume of EDs. I think it's down maybe closer to 3,800 now, but that's $5 million a day, okay? So there's a huge, huge benefit to the big picture, and there's a huge benefit to you on a day-to-day basis, and I think there's a great benefit to the patients also if we're doing things better and being more lean with our operations. Any questions?